screws, which are now approved in the U.S., have been for a couple years, and we can get some good cement augmentation. In this particular case, I did 2 above and 2 below. I think with cement augmentation, we're able to get these construct sizes down a little bit and also avoid anterior column reconstruction. So here we get a screw in at that level where there's a lot of lytic disease and high-grade compression, decompress on the contralateral side, size the screw up, put it in accurately. If you're using fenestrated screws, you want to make sure that you're not going to extravasate cement anywhere. That's kind of one of the primary problems with cement. So we go in, put in our screws, and then come back and blow cement in behind them and get the patient off the table. I'm now, this was done open. This was done 2 above and 2 below in a more traditional fashion, but we're trying to do this a little smaller now. I think my time is up. This last case is simply to illustrate a case that I did right at the beginning when I first started, about 3 years ago. When I first got back here, it was in summer. Patient fell. She had a previous scoli correction at the age of 12, really severe deformity, no recognizable anatomy. She had a T12L1 3-column fracture, and we took her in and opened up, and really there was no recognizable landmarks. This was just a large sheet of bone. So in order to get any fixation here, navigation was absolutely critical. So those are just some of the examples, I think, of cases where these are all open. This is an example of interbody implants where they can also help you. I think it's a great place to transition when you're going to learn how to use 3D navigation, is to go from your normal fluoro-based case where you feel very comfortable using navigation in an open fashion, and then transitioning more to the MIS applications. So in summary, it's an adjunct to fluoroscopy. It's really the platform to build MIS, to build from robotics, and to build onto augmented reality. And there are a lot of future iterations, I think, that are really exciting, that are coming. They aren't quite here yet, but a lot of people working on them, and I think those are going to be available soon. So I think it's exciting times ahead, and we're probably going to hear about a lot of that in the next couple talks. So thank you very much.
Yeah, thanks, Mike. That was a great summary of how to incorporate navigation into your practice. Yes, do you have a question, comment?
Yes. Regarding longer constructs, do you feel that you have any limitation regarding the positioning of your reference towards your last level instrumented?
Yeah, I think everyone has a different tolerance for how far they want to work away from the array, and it totally depends on if you're doing a previous instrumented fusion where you're just extending above and the anatomy is totally fused, right? A patient is L2 to 5 and you're just extending them above and below. That's going to be a very solid anatomy. Whereas if you have a patient that's de novo, they're young, it's tumor, they're going to be moving a lot. I tend to start up high and work toward the array. Always, there's simple concepts I think that are important to practice, but we keep going farther and farther away. So working farther and farther away to try to find what that accuracy is. If we're doing something like a T10 to pelvis, that often requires 2 stages. So we will, get a scan with a reference in the middle, instrument, check, scan the rest of it, and then the instrument below, and that helps a lot with that. I'm even more cautious in the cervical spine. So oftentimes I'll do C2 and C1 separately, and then do the junction and freehand all the mid subaxial cervical. So it depends on what you're doing, but there is certainly a concern there with respect to distance from the ray, because that introduces inaccuracies.
Maybe show of hand, how many here in the audience, spine surgeons, how many use navigation for spinal surgery on a regular basis? How many of you feel uncomfortable now doing cases without navigation, or certain types of cases without navigation? So is that bad, or is that good or bad? I don't know. But that's, I'll be the first one to admit that putting in, K-wire, AP lateral fluoroscopy screws, I'm not very comfortable, and I try to avoid that. Avelino, we had a meeting a few years ago. I remember we met in Munich at Brain Lab, and that was right after you started using navigation, and you were very hesitant. You were very kind of reluctant, and now obviously you're a big navigator. What happened? How did your learning curve kind of change, or what made you more comfortable?
Yeah, I told you I was thinking about abandoning the navigation, because at the beginning it took me almost double the time to do every case. But I think what you have to do is use it every day, use it in the simple cases, use it for the open, simple 4 or 6 lumbar screws. That way you get used to navigation, and all the team gets the workflow when to put the CT, when to take it out. So now we are using both systems. We are using the Aero, and we are using the Medtronic arm, and I'm very happy with navigation. And then now the time it takes is shorter even than with navigation than without navigation. And about feeling uncomfortable, yes, I'm afraid of that, and that's the reason why I still try to do some cases with X-rays, because obviously if you only use navigation, maybe you are not so comfortable. But I'm sure it's just a feeling and nothing.
All right, any tips for surgeons who start using navigation to make sure it's really accurate? Like in terms of positioning in the operating room, or what to do, what not to do?
Yeah, I think it's really important to lock the patient in. You know, we spend a lot of time securing the patient so they're not moving, you can't have them move. When you're in the lateral position particularly, you know, Roger's really pushing the limits with respect to what he'll feel comfortable. I still like to have a 3D reconstructive sort of image acquisition device so I can still take some fluoros in the lateral, because I think when you're in the lateral, the farther away you get from that reference in lateral as opposed to being in a Jackson or something where you're really locked in, the more that upper torso kind of moves independently. So if you're doing single position surgery, you've done some nice inner bodies, and you come up, do some lateral, and then you're going to come from behind and put in all of your pedicle screws. That's fine to start down at the bottom. You're not going to have too many problems at L5, L4, S1. That's not really too much of a problem. But when you're up and around L2, L3, you got to be really careful pushing on the patient and moving. I think it's very, very important. You'll develop almost a nervous tick the more you use it, of just checking. I'm always checking, kind of tapping on known, you know, even if it's just MIS and deep and paramedian incisions, you can feel TPs, joint, all the different things that you already know. And if that navigation looks accurate, you're accurate. And if not, it's time to, you know, reassess.
Yes, yeah, Oscar.
Segments like C1, C2. You know, sometimes you're just cannulating a pedicle and the vertebra moves. So any trick, any...
You know, when I'm doing OC1, C2, a couple things. I like to put the reference on the C2 spinous process, point it up over the back of the head and over the top. Instrument C1, and then instrument C2. And C2, it's always going to be moving with you, right? So even if you're putting a little too much pressure, you're going to be able to hit the pedicles because the reference is moving with you. And then, you know, occiput, you generally don't need as much navigation. It's not as important, but that's what I like to do. And I like to do that separately from the cervico-thoracic junction. So if I'm going down that far, it just there's too much movement in the cervical spine.
Hi, Jason Perrin from Mannheim again. You asked if there's any tips, like if you're unsecure with the accuracy, and especially when you said the learning curve is best to start with open, simple cases. What you can do is put in like little screws as bone fiducials, which you can always re-reference and check the accuracy. Is also a very good procedure for open cases. And then what's your experience? Do you use a drill, or do you always use an awl? Because we're talking about the preparation, the pressure that you have, but when you have a navigated drill, you kind of eliminate that factor?
Yeah, you used a whole variety of different things. I don't like to do any malleting or any hammering on a patient who's got terrible thoracic stenosis, tumor case. You know, I want to put my screws in first before I do the decompression. I'm not going to be banging around with an all tip tap. You know, that we'll use a navigated drill, put a navigation on a little, you know, matchstick or something like that, put that down, and then put in then go back with an awl, and then go back with your screw. So there's a lot of different, you got to have a lot of different tools. It's just mainly the, you know, thoracolumbar degenerative disease that I'll go in with something that's a little bit more forceful. And there's navigated lanky, you know, there's all kinds of different adjuncts, but I think drills are probably the nicest right now if you don't want to put any pressure on someone who's got high-grade stenosis in the cervicothoracic regions.
Gianluca has a question.
So accuracy can change if we use pre-op CT plus 2D fluoro versus 3D fluoro or OARM.
So is the accuracy different between these systems?
Yeah.
I've used OARM, Aero, Zeem, all these systems. So Stealth, and Brain Lab. Most I've used those systems the most, and that's what I'm most comfortable with. And I think that they're both excellent. I have not used a lot of 2D registration to match to preoperative, so doing segmental registration. Although I know that this is all it's becoming ubiquitous, right? All the companies are having a system like this so that you don't have to get an repeat intraoperative navigation. Now, how good is this? I think it's probably good for bony anatomy, but disc spaces are going to change. A little bit of rotation is going to change. If you're doing osteotomies or decompressions based on that, I think you have to be careful. You certainly wouldn't be able to register. I wouldn't feel as comfortable with some of the vascular anatomy or a large tumor if I was working at the OC junction or something. That's not going to translate very well. But bony anatomy, with respect to segmental registration on preoperative imaging, is probably pretty decent. I haven't used it yet, though, so I don't really know.
Yeah, it's a good question. I think we've got to move on. Taylor's keeping us on our toes.
Great. All right, thank you.
Thanks so much. We'll have Dr. Protopsaltis from NYU, who's going to talk to us about robotic surgery. He's a big proponent and master of MIS surgery. Thanks for being here.
Thank you.
And obviously robotics as well. Great.
Thank you very much, Roger, and thanks for the invitation to come and speak about robotics. And at our institution, we really embraced it when we felt that the technology, as Dr. Verk had mentioned, has come up to the point where it can be more ubiquitous for everyone to utilize. And when robotics and navigation are married together, I think it can be fairly powerful. So these are my disclosures, and I should mention particularly that I do consult for Globus specific to robotic surgery. So I'm going to discuss, just as an overview, advantages for robotic surgery, particularly with single position lateral, for MIS degenerative cases, for skew accuracy in all kinds of deformities in the spine, S2 alar iliacs, MIS deformity and percutaneous screws, as well as open deformity cases, and doing things like PJK prevention with percutaneously placing the UIV. So I think there's a lot of advantages, and you can see this is probably a huge topic, much more than we can cover in one section. We could probably talk about each of these in a separate talk. Just by way of literature, I don't want to bore you guys with things that you might already know, but the whole reason to move to something like navigation is that there's the concept that this is a more accurate way of placing your pedicle screws. And I'm not going to go through a ton of studies. These are just a few meta-analyses that show that navigated pedicle screws are much more accurate with a 0.4% malpositioning rate versus 1.14 using freehand technique. And you may say that some of these studies may be biased because the people embracing the technology are probably utilizing it most effectively. But I think it's true that on the whole, you're looking at the anatomy real time and not making somewhat of a guess based on what you're seeing posteriorly. This is a meta-analysis of robotic accuracy rates. And you can see rates ranging from 85 to 100% and a reduction in fluoro time. We did a study at our institution, and the amount of radiation that the patient was exposed to was twice as much with fluoroscopically placed pedicle screws as with our robotic and navigated pedicle screws, and that included the majority of those patients getting preoperative CTs, which were factored into the actual radiation dose. So there's a significant savings. I mean, obviously, if you do it freehand open and you don't get a preoperative CT, that's the lowest amount of radiation exposure to a patient. But you have to think about not only your patient, but yourself and the staff around you. And I can tell you that our staff are much happier in the navigated rooms than the fluoroscopic rooms. So in degenerative surgery, screw accuracy is something we mentioned already. In minimally invasive surgery, I no longer put lead on, which is a huge quality of life improvement in my opinion. And I think the future will have navigated interbody instruments, which is also going to be making things a lot easier and not having us to bring in fluoroscopy again and radiate the patient and everyone in the room. And then I think this is a seamless transition to single position lateral. And I didn't embrace this type of surgery until robotics came out. I was doing some cases fluoroscopically using single position lateral, but until the robot came out, I really didn't embrace it, partly because it takes a toll to wear lead and be in a lateral position and put downside screws, and I didn't want to do unilateral fixation. We've looked at this in detail, and I think some of the advantages are that you can do more anterior interbodies, like with A-lifts in the lateral position and with laterals in the lateral position. The lordosis restoration is significant because you're doing an ALL release, you're restoring disc height and therefore foraminal height. So I think there's a lot of advantages to single position because of that. And then it transitions nicely into minimally invasive surgery, and you can do all the axes simultaneously, anterior, lateral, posterior. You can be working in two places at once, which is a huge improvement. And there's no repositioning, no flip, no reprepping, no redraping, and you close the wounds simultaneously. So we actually looked at our institutional experience, and this included both fluoroscopically placed screws as well as screws that we placed with the robot. And our cohorts were pretty well matched between the single position patients and the reposition patients, but the operative time was 110 minutes less. And you could say, well, my institution, we don't flip. I think I heard Bob say that just last session, that we're really efficient, but at the end of the day, you're still closing the wound sequentially, you're still reprepping, and you're redraping. So there's going to be a time savings. The question is it 30 minutes or is it 2 hours? Which two studies that have come out so far have shown that it's actually 2 hours, which is daunting. So it's also the reason why I wasn't doing lateral surgery at 4-5 and then flipping the patient and doing posterior percutaneous screws. I was doing T-lifts up until the robot came along and I started embracing single position surgery. So I think there's a lot of advantages. Here's a case of mine. This is kind of like a mini deformity, mostly a lumbar curve. The patient had right-sided radiculopathy in the concavity of that major lumbar curve, which is apex at L2-3 there. A little bit of a lateral lucesis at L3-4. So I felt that this would be a great case for a single position lateral. You can see my approach surgeon on the left in the upper left picture working on the ALIF, and I'm putting all my screws in. And for this particular case, we used preoperative CT. We justified with an intraoperative fluoro. I got all the screws in before we changed any of the anatomy, so the accuracy was good. And then once the ALIF was actually exposed at 4-5 and 5-1, went over, did the ALIFs, and then finished with two laterals, closed the wound simultaneously, minimally invasively. In this particular case, I use a kickstand as well to push the spine over after I locked in a short rod to maintain the fractional curve lordosis, techniques that I've learned doing open surgery. It does require a little mini open to get a distractor in. So that area where you see a double-headed tulip was a slight mini open area, but the rest of this case was done percutaneously. And the overall alignment's pretty good. She's got a leg length discrepancy, which explains why she's got that residual curve above it. But I think with a shoe lift, that'll balance out, and she's much better corrected. Her radiculopathy went away, and she was feeling like $1 million at 6 weeks, which you could argue in a very efficient open surgery should be pretty similar, but I figured this would be a good application of the technique and the technology. So bringing us to deformity, I think that there's a lot of advantage for placing your screws in rotational deformities accurately. There's not much difference per se between navigation and robotics, except that the robot helps guide your arm. What that means is I let medical students put in pedicle screws now, and I have no stress because I can see what they're doing. I can see on the screen what's happening. And if I think something's not going right, the computer and the feel of what's going on will tell me, and I can intervene and make sure that the screw goes in the right place. So medical students, fellows, I'm not placing as many of my screws anymore, even in challenging cases like single position lateral. S2 alar iliac screws, you can line that up so that the rod passes effortlessly. The tulips can be kissing practically, so there's no place for that rod to go but from S1 right into the S2 alar. MIS deformity, percutaneous screws, we kind of covered that in that case example. Perking the UIV to prevent PJK. Some authors have talked about that, like Kalkabesh. This is clearly something that you'd think would be a great application for it. Placing these screws in this complex deformity. This is the actual case. She's got sagittal and coronal deformity, and she's got a nice correction in both the planes with quite an extensive surgery, which I didn't do minimally invasively. And another case of an adjacent segment degeneration, kyphosis, proximal junctional failure, robotic assistance, screw placement, realignment. This is a complex case, surgery done elsewhere, mainly complaining of lower back pain. She does have pseudo at the top, and that cervical instrumentation in the upper thoracic spine is pulling out, but she mainly complained of adjacent disease at the 5-1 grade 2 spondylolisthesis, and then she had an adjacent degeneration at 3-4, so extended down and up, and did a single position lateral again, ALIF at 5-1, and a lateral at 3-4. Percutaneously placed the screws, retained some of the hardware, and bypassed it with an S2 Ailer. So I was happy with the overall, the way that this case flowed and the efficiency of it. And she's now saying that went so well, then I want to address the upper thoracic part. Last case, again, a lot of rotational deformity, great case for robotic assistance, placed the percutaneous UIV screws for PJK prevention, and was happy with the sagittal and coronal result. And I think that one other thing that navigation is gonna leap towards is intraoperative verification of our realignments. There's no reason why we can't use navigated instruments to, for example, on the fly, check an S1 screw and make that the new reference point, and then measure the position of the UIV, and we'll know exactly where that pelvic angle is relative to the UIV. So I think that'll be the future of robotics and navigation. Thank you very much.
Thank you. It was really interesting. A question, if there's no question right now from the audience, there is though. Gianluca.
So in those logo construct, do you need to change the reference several times?
Yeah, I tried to do, for something T4 to the pelvis, 2 acquisitions. So I find that you have fairly good accuracy T10 to the pelvis. What I do is I ask my radiologist to get me axial cuts with 1 millimeter cuts from T10 to the sciatic notches when I order a lumbar CT. They'll do that for me, and then I have all of that in one acquisition. So I'm not switching between 2 studies. And I'm going from T10, starting most distally. Actually, what I do is I place the T11 screws. I don't expose the T10 start point. If the anatomy makes sense at T11, I percutaneously place T10 and then march down. And the accuracy diminishes the longer the case goes on and the farther away you are from the DRB, but it's at its best the minute you do, the minute you start. So that's why you start distal to proximal. And place the screws first. If I'm going to do T-lifts, inner bodies, osteotomies, I don't do that right away. If I need to do a lot of work, I'll place headless screws, then work around the headless screws. The headless screw helps me mark my anatomy. I'm no longer navigating at that point, really, or relying on the navigation. And then when you want to complete the T4, you do it staged, you expose it staged, so the patient's not bleeding from an entire wound, the whole case. So you expose the bottom, then you expose the top, and then you reposition a fiducial. At our place, we have both intraoperative 3D imaging options, as well as the preoperative CT, which we've done a lot of, marrying with intraoperative fluoro. And the robot also allows for 2-dimensional navigation, as if you're placing screws with Jamshidi needles, but you're just using the robot, and you're taking pure AP and lateral fluoro shots and then just navigating off the 2D, not taking a million fluoro shots to get your pedicle screw in. So there's lots of different options, but generally speaking, 2 acquisitions for a long construct like that.
Maybe a question that goes kind of similar direction, but I have a really hard time imagining that especially if you have those severe deformity cases, that you can match a preoperative CT with intraoperative X-rays really accurately. I mean, we use intraoperative CT scan and we go through all types of hoops to make sure there's no movement, and even then sometimes it's not 100%. How can you match those anatomies? That seems hard.
You have to use 3D. It's the best, because otherwise the robot gets confused, or a navigated pre-op CT to intraoperative fluoro will get confused and will lead to inaccuracy. Not to mention that frequently these patients have osteoporosis, so you need something that gives you a powerful, high dose intraoperative 3-dimensional image for that. You're absolutely right.
Right. That's- And you mentioned that you plan the screw heads so it makes it easier then to pass the rod. Does the software allow you to plan screws in such a way that the screw heads are aligned, but the actual screw goes into different directions?
Yeah, absolutely. You can manipulate a three-dimensional model on the computer and see, looking at it as if you're going through an axial through each level. And at some point, they're going to navigate rod passage for percutaneous cases. So that'll be nice. But at the end of the day, not only am I planning the screws so that they meet up, but I'm also planning the incisions so that I'm using the minimum number of incisions as well. So you can line up your screw trajectory so that L5 is not coming out of left field from the side of the patient. You can cheat the screw to be more straight away in order to make it match with 4 and 1.
Right.
So-
No, but can you tell the software that to make sure that, let's say, the screw heads are aligned, or do you have to manually plan yourself every screw? So, and you look at it to make sure that they're aligned.
So I have my fellow do all the planning, and then I come in and change it so that everything lines up. So I still do it manually.
I'm just wondering, it would be nice if the software would just give you like that option, and then you could just, I'm sure it's some people working on that, I'm sure. All right, any other questions or comments? That was a great talk. Thank you so
Thanks.
much. And we'll move on. We'll have next our really last presentation of the day. We have Dr. Whitham from Hopkins is going to talk about augmented reality in spinal surgery.
He's got it minimized down here, but I gotta wait for him.
Has anybody used augmented reality? Anybody used it for spinal procedures here? Yes, of course. Yeah, Adrian. Yeah,
And then it's that one. Yeah, there we go. Okay, he's got it.
Francie. All right, thanks.
Thank you. Yeah, so I'd really like to thank Dr. Hartle, Dr. Pimenta for allowing me to share with you some of the work that we've done at Johns Hopkins with augmented reality and navigation and instrumentation placement. So my biggest disclosure is probably sort of a confession. I am not somebody who does MIS cases. I do almost no MIS cases. I do very few navigated cases. I got interested in this technology actually through one of our chief residents, Camilla Molina, who's going to give a talk tomorrow, when he asked me to show up on a Saturday afternoon and put some pedicle screws into cadaver using a new navigation system. To be honest with you, I was in a rush and I just wanted to get out of there. But I found this technology to be very interesting, and I think potentially the wave of the future in terms of navigation, and has the ability to line up with many of these other technologies that we've heard about today. I am a consultant and medical advisory board member and investor in Augmetics, who makes a head-mounted display augmented reality system that I'm going to tell you more about. Now, traditional navigation, as we've seen today, is very helpful in placement of spinal instrumentation, but there's always this attention shift away from the patient as pictured here. The surgeon always has to look to a remote camera, and that takes our attention off the patient, and we're all used to focusing on the patient when we're operating as spine surgeons. Similarly, robotic technology, same thing. So augmented reality is a technology that superimposes a computer-generated image on the user's view of the real world, thus augmenting or providing a composite view. What are some of the technical drawbacks? We've heard about many of these already today. Line of sight interruption. If you get in the way of the camera in the reference frame, that causes a disruption in your workflow and can be quite disrupting. There's a learning curve to all of these technologies. Replication of inline maneuvers when placing instrumentation is very important. We saw that in the last talk. Entry point shift, skiving, and then attention shift. We're looking away from the patient. Attention shift has been shown to affect cognitive and technical abilities in psychological studies. So what are some of the solutions to this? Well, augmented reality could offer some solutions. There are several that are in the works already. There's a system that has a microscope-mediated heads-up display. There is a system that uses a remote screen image overlay. And then Augmetics and the X-Vision has developed a head-mounted display, which I'll tell you more about. Dr. Barbara Karl and their group in Marburg, Germany, has published already on the use of a heads-up display inside of a microscope. This is used in conjunction with the BrainLab system, where you have a camera that tracks both the microscope itself and a reference frame. And in these situations, this can provide some very neat image overlays, including the bony anatomy, and tumors, and can help assist, just like with brain surgery with resection of tumors, in your approach to that tumor in terms of your bony work, your dural opening, and providing you with landmarks to help assist you with this type of surgery. I think Dr. Elmi Terender is here at this meeting. He will, I think, talk about this more tomorrow, but they've published on the use of this remote image display for augmented reality using a Philips system that has a C-arm with cone beam CT capabilities in a 2D and a 3D plane. The camera is mounted directly on the image intensifier, and then there's a remote screen whereby you can capture the augmented overlay onto a real view of the surgical site. They've done a cadaver study, and I believe also they do have clinical studies that I think they'll talk more about, comparing the freehand technology to this augmented reality system with a significant improvement using the augmented reality system. I will say that in all fairness to those of us that again, do the majority of my cases freehand, this is a bit of a low number. The 64% I think for freehand is probably lower than I think most of us that can perform this type of technique well. The X-Vision is a heads-up mounted display that has the entire navigation system within this head-mounted system. There's a camera that is part of the headset, and then images get directly superimposed on the retina through these glasses, and I'll show you what that looks like to the surgeon. There's a 3D reconstructed image of the spine, which is in that heads-up mounted display, and then a sagittal and axial image that allows you to navigate when you're placing your instrumentation. The system is what we would call a vendor agnostic system at this point. The reference can be attached to any instrument, so it could be used with any pedicle screw instrumentation at this point. The clamps are meant to go on the spinous processes and are specially designed to be implanted through a very small, almost percutaneous type of incision. And they're designed to grab onto the base of several spinous processes to prevent movement. So I had a chance to participate in this study that we did at Johns Hopkins looking at placement using this system in 5 cadaveric specimens. Several of my colleagues were involved, as well as a group from Israel, as the Augmetics company was originally started in Israel. So we looked at 5 cadaveric torsos. Registration clamps were placed with 2 CT spins at 2 different areas of the spine, from one at T8, one at L3. We obtained a CT acquisition post-clamp placement, and then the spines were instrumented from T6 to L5 in all situations. This was a total of 120 pedicle screws. So what happens is there's a CT spin. That DICOM information gets sent to a tablet that's in the operating room that then reconstructs that into a 3D image and segments those images, and then through a Wi-Fi system sends that information, the segmented information, to the headset, which then does all of the navigating. In this study, surgeons were allowed to use whichever types of tools they are normally accustomed to. It was done open in this initial study. So you could have an all pedicle finder, you could use power, you could place the screws manually, whatever your preference was. So again, that's a picture. So we use the Gerspine-Robbins classification system, in which case the A and the B category are considered to be accurately placed screws. We also used a slight modification of the Heery grading system as well, and looked at the accuracy rates with both of these systems. So if you look at the Heery system, thoracic screw placement, the range from each surgeon, so the lowest was a 92.9% placement. The upper surgeon was 100% for an average of 97.1 in the thoracic spine. Lumbar spine, it ranged from 90 to 100. And the total using that grading system for the thoracic and lumbar was 96.6. Looking at the Gerspine system, again, thoracic ranged from 90 to 100 for an average of 93.5. And then lumbar 90 to 100, and then the total average for thoracic and lumbar was 94.6. And then what we did is we tried to compare this to reference points in the literature based on meta-analyses. And I'm not a statistician, but what we looked at was a least squares analysis in a lower one-sided 95% confidence interval, such that if the number that I'm going to show you in this table was less than greater than negative 10, then it was non-inferior. If it was greater than 0, then it was considered to be superior. So we look at our accuracy rate using the Gerspine system of 94.7% and Heery 96.7. We compare that to reference points for freehand placement, manual navigation, and then robotic placement. And then you look at these numbers below. So basically, any number that's greater than negative 10 is non-inferior. So compared to freehand, well, let's start here with regular navigation. So for regular navigation, using both grading scales, we're non-inferior. For the robotics placement, let's see, using the Gerspine, we're non-inferior, but for the Heery, we're superior. And then compared to freehand, it's superior in both grading scales. We also, there was a survey at the end where the surgeons that use this technology had a chance to sort of grade this system based on various qualities or characteristics. And as you can see, the numbers were all very high here, particularly for novelty. And it's really an eye catcher when you first try out this system. It's really kind of, you feel like you're playing a computer game or you're a pilot in the cockpit. And that's sort of what the technology was based on, was actually heads-up displays for Air Force technology. I guess I'm getting cut off here. The last several slides, I'll just summarize very quickly, had to do with, there's been an initial clinical study in Israel for their FDA type of approval, which showed high accuracy rates. And this system, I think, will integrate with robotics. We're going to be able to do other advanced things with it, like osteotomy placements, interbody placements, and so forth. Additionally, we're also working on getting a preoperative spin to register. Thank you.
Thanks a lot. Any questions, comments? I have a hard time imagining that surgeons are really going to be comfortable with those displays on their head, or those goggles. Do we have any experience in that?
Yeah. So I've worn the system. I've used the system. It's a lot like wearing a headlight, to be honest with you. And I think as the technology improves, it's a little bit heavy. It's a little bit cumbersome. Obviously, you wouldn't wear it for the entire case. You'd take it off when you're doing a lot of the case, other than the instrumentation placement. But I think actually, as a surgeon, for me, it's much more intuitive to use rather than looking away. Now, obviously, many of the folks in the room here are used to doing MIS and navigated cases, but for me, when my attention is focused primarily on the patient, it's more of a natural maneuver for me, I think.
Is there any reason why you wouldn't be able to use it like with an exoscope kind of setup where you have a camera and then you look at a display, you just look straight ahead, and or is that you think that's not a good idea?
Yeah, well, I mean, I think that's the concept is we're trying to get away from having a remote image display and the attention is on the patient.
Right.
I'll add that we are working with Zeiss to be able to take data from the exoscope, and rather than you looking at a remote display directly using our direct retinal display, to not have to shift your attention away from the patient, have a more natural feel that you're used to the microscope or something like that.
So a magnified view. Yeah.
Right in front of you, and usually in the surgery you are constantly moving your head, and sometimes you don't have a 3D vision. So what do you think about that?
I don't know. I'm just wondering that wearing that device on your head is not ideal either. But maybe you're right. So you think you don't have the three-dimensional.
The thing is that to have a 3D vision, you need the glasses. I'm talking about the exoscope now.
Yeah.
But you need to have your screen right in front, because if you move a little bit, then you lose the 3D. And during the surgery, you always move your head. So sometimes you see 3D, sometimes you see something a little bit blurry.
I think that depends on the system, though. We use the Olympus, and that seems to be. I have noticed that.
They are by.
Pardon?
They are by from Olympus, yeah.
Yeah. Is
and
that, I have noticed that. But maybe you're right.
Yeah, I think you're talking about your focal length. If you change your focal length with the traditional glasses you have to put on to see the 3D overlay on the remote screen, if you move your head around, you lose that 3D feel, right? That's one of the benefits that we're thinking of we would get rid of by putting it on our head-mounted display, because your interpupillary distance from the retinal display is never going to change no matter how you move your head. So you're never going to have that loss of 3D.
So you combine the exoscope with the.
That's in our long-term goals, and we are actively working with Zeiss to do that. But that is one of the potential benefits of why they wanted to collaborate with us for that precise purpose, because these headsets are going to be configured to each surgeon, so that there's an interpupillary distance that's different for every person, and if it comes directly customized to you, it's going to say, 3D-dimensional vision the entire time, no matter how much you move your head or your eyes for that purpose.
Also, just a reminder, there will be a station in the cadaver lab on Saturday, so you'll be able to try it out if you want to give it a shot. Yeah.
But let me ask you that question now. When navigation was introduced, the data show that there's a real reason why navigation is helpful, because it improves accuracy, right? What's really the advantage of augmented reality for pedicle screws? Is there anything other than is it like endoscopy versus tubular? Is this another way of doing a microdiscectomy? Another inflammatory comment, or is there a real advantage? Or is the advantage down the road at some point?
I think in this case, I think the 3D model that you see, I think does help in my mind as as an open freehand surgeon. It helps me to confirm the entry site on the 3D model. But outside of that, that part of that's really the augmented reality part of it. I agree with you. I don't think it adds a whole lot. But for me, I think having the heads-up mounted display that's really the novelty of it, and I think that's where the benefit is, preventing the attention shift.
Yeah, and I'll add to that. I think when you look at the literature, the penetration of computer navigation is only about 25 to 30%, depending on what data you look at. And a lot of the people that haven't switched over for it, and notwithstanding cost and availability of advanced 3D image acquisition, is because they when they start the steep learning curve of computer navigation, If it makes an error, they don't trust it anymore and they stop using it, or they find it too cumbersome to constantly be shifting away their attention from to a remote screen away from the patient. And that's where people that we studied this make mistakes, right? Because, for example, they're cannulating a pedicle and they're like, I need to medialize more. And they're looking at a screen and they're medializing, but they're not looking at the patient. And what they're doing is they're actually just rotating the spine, or they're moving the whole patient as they drop their hand, or they have entrance point shifts that they didn't realize are happening, and it looks perfect on the screen, but it doesn't look it's not actually going in where they thought it is. So I think that discourages people because they see a phantom screw placement that doesn't look like that way in a post-operative CT, so then they stop trusting the technologies. But the technologies at work, it's human error. And we developed this to get rid of that gap, that learning curve, to not make that human error, so you can trust the computer navigation. So I think that's a big thing. And then one of the other data that we're going to look at and we're going to talk about tomorrow is precision, right? Not just accuracy. So are the screws ending up where you think they ended up, right? Because clinically accurate is different from precision. So we're going to look at, did our phantom screw actually end up where the post-op CT says it is? Because none of the actual navigation data is out there, except for very few studies talk about that, because the reality is that most of it doesn't end up where the phantom screw is. It just happens to be a clinically acceptable screw. And that's why the accuracy rates for navigation are still not unanimously 100%.
Yeah, I was just going to add real quickly, the price point is significantly lower than the navigation system. Yeah.
Yes.
Well, I think that for the augmented reality, I guess the first step for the future. With the advancement of the technology, we will see that we're going to use it for complex tumor surgeries. Today, we can merge the CT, MRI, and PET scans all together and see the environment of the tumor. So I believe that within 2 to 5 years, we can easily use it for the tumor surgery. Just this is the starting point for putting a screw with the augmented reality.
Yeah, I agree with that.
The other thing is obviously teaching and training, right? And you have a system here that really takes advantage of that. So, all right. Well, thanks a lot. That was great.
Thank you.
And we'll hear again from you tomorrow morning. I think about, right?
What's that?
Are you speaking tomorrow morning again?
Yeah.
Yeah.
Robotic.
Yeah. So anyway, I put together a few kind of thoughts about the day, and I don't want to hold you up longer than necessary. Everybody's eager to get out of here. But basically, we heard a lot about endoscopic versus tubular surgery. I think the verdict is still out. Which one is better, or is it just really a stepping stool towards more complicated and complex procedures? And is that the real value of engaging in endoscopic surgery, which I think it probably is. And we had a nice presentation about spinal tumors. I think that's a real advantage of MIS surgery. These tumor procedures sometimes can be fairly invasive, and there are real MIS options now to make the surgery safer and more effective. I was surprised to hear about the Wagner arch. Unfortunately, Dr. Wagner is not here now. Otherwise, we could have had a little debate here. And then Eric Elowitz reminded us that with age comes wisdom, but sometimes age comes alone. I thought that was quite witty. And then we were surprised to hear about single position prone transpsoas surgery. And it sounds like a really great concept. The more you think about it, though, the more kind of doubts creep up, and you're wondering how is that really going to work out. But I'm sure it probably will over time, and it sounds like a really challenging and probably worthwhile endeavor to kind of explore. And then the deformity algorithm, right? I think that was really interesting what Kai Fu talked about, and Greg, of course, and then finally robotics and augmented reality. So I think we kind of have a base to stand on for the next 2 days. We learned a lot about the basics of MIS, robotics, navigation, and so forth. And I'm really looking forward to a lively meeting tomorrow with lots of discussions, and then finally the cadaver portion and the practical course, portion on Saturday. I want to remind the faculty tonight at 6:30, we're going to meet at the Explorer Club for drinks, and after that, it's going to be a free evening. So thank you so much, and have a safe trip home if you go home or whatever you do tonight. Have fun. Thank you.